A very good evening to all of you. So the today's tutorial is about, or we are going to discuss something about how to present a case of abnormal uterine bleeding. Now, abnormal uterine bleeding is a symptomatology which is used, or it's a term used when the patient has deviation from normal menses, right? It could be anything from menorrhagia to the up to amenorrhea, or even oligomenorrhea, hypomenorrhea, like that. So the whole concept of this tutorial is to guide you on how to take a case for menorrhagia, right? So let's see what we have in the case, right? So this is a case where she is 38-year-old who is complaining of menorrhagia since last 6 months. She is para 3, living 3. Her tubal ligation has been done, right? What is her menstrual history? Her past menstrual history has been 3 to 4 days of duration. It used to come every 30 days and there was no dysmenorrhea. But presently, when she's having this menorrhagia, she's been having the duration of menses has increased to 8 to 10 days, and it's been every 30 days, and it is associated with dysmenorrhea. Now, per abdomen, on examination, general examination, there is nothing abnormal as such. On per abdomen, the abdomen is soft. On per speculum examination, cervix is healthy and vagina is healthy. On per vaginum examination, the uterus is bulky, anteverted, anteflexed, and bilateral cornices are non-tender. Right. Now coming to this particular history, whenever you take any Gynec case, always remember that you have to first take the history properly. In history, in Gynec examination, especially for undergraduate, we are not telling you to take the case in reality. What we do is we are giving you templates, right? On those templates, certain information is given in a very short summary sort of way, right? So in this patient, the patient's age is 38-year-old. She is having menorrhagia. That means she is having excessive bleeding period. Now the questions which can be asked to you, like how would you elaborate this history? So in menorrhagia, you are supposed to ask how much is the amount of bleeding which has increased. So how will you assess that? So you on history you can ask if she was using say around 3 to 4 pads per day. Now she is requiring almost 7 to 8 pads per day. But then again, this is a very subjective thing because some patients may use, say for similar amount of bleeding, some patients may use 4 pads and some may use 8 pads. So how do you assess clinically whether this patient has really menorrhagia or not? So try to understand that menstrual blood normally does not clot because of the presence of fibrinolysin. When the patient has bleeding which is excessive in amount, or the endometrium which is shredding is excessive in amount than the fibrinolysin present, the menstrual blood starts clotting. So whenever there is history of passage of clots, that means the amount of bleeding is excessive than the amount of fibrinolysin present in the endometrium, right? Then the patients start producing clots. So that is one history you may ask to quantify clinically or by history whether the patient has menorrhagia. Now coming to the clinical examination. On clinical examination, then other menstrual histories which you have to ask is she having any dysmenorrhea associated with it, and is she having any polymenorrhea? So when you say polymenorrhea, that means the cyclicity of the patient has changed. Menstrual cycle has changed. That means what? The HPO axis is somewhere affected. The hypothalamo-pituitary ovarian axis is somewhere affected, and that is causing changes in the menstrual pattern also. So there could be that cause related to that kind of AUB. And only menorrhagia per se, that means the cyclicity has not changed and only the amount has increased, that means there is some local pathology, right? Now coming to the causes of AUB as such, if you see, it is divided by International Federation FIGO into PALM and COIN. This is a mnemonic which is used. So PALM is P is for polyp, A is for adenomyosis, L is for leiomyoma, M is for malignancy. And the coin part, so the palm coin is related to the local pathology in the uterus, and the coin part is related to the systemic causes of the menorrhagia. So coin means C is for coagulation, O is for ovulatory dysfunction, I is for idiopathic, like that you have for palm and coin, right? So for local pathology, the palm part, the generally the history as histories of menorrhagia and dysmenorrhea. And when you have the other coin part affected, there could be any endocrine cause, like if there is a thyroid problem, then the patient may have little problem with the cyclicity also. So taking menstrual history properly plays a very important role while discussing a case of abnormal uterine bleeding, right? So this is about history. Then coming to the examination point of view. In examination point of view, in general examination, these patients, what positive findings they could have. So as I said, you must see for any thyroid enlargement. Is she having pallor? That will suggest that whether she really has menorrhagia and as it caused anemia in the patient. And is she hypertensive? Is she obese? Is she having any other like acanthosis, like hyperinsulinism, or it could be menorrhagia associated with polycystic ovaries. So all these factors, is there any hirsutism, acne, all those things have to be checked in cases of menorrhagia. Specifically, thyroid has to be seen for every case of, in fact, for every Gynec case, you must see for thyroid of women. And thyroid diseases are 5 times common than in females than in males, especially after the age of 40. Right. So this is all about history as such. Then coming to the clinical examination. In clinical examination, you must see in general examination, once we have seen all this thyroid panel, you're going to go to the per abdomen examination. Specifically in per abdomen examination, you must see for any abdominal lump, any distension, or on palpation for any tenderness, for any palpable mass, any pelvic mass. All those things have to be checked for for cases of menorrhagia. Now, the findings which have been given in this patient have been that the cervix and vagina are healthy and the uterus is just bulky. That means what? The uterus is regularly enlarged. It is not having any oscillations, and it is the uterus which is just normal than normal size. So, what all causes could be there out of this palm coin? So, mostly they are going to be somewhere in the palm. If general examination is not showing anything abnormal, the cause is going to be from palm. That means polypedenomyosis, leiomyoma, or malignancy, right? So at the age of 38 years, that means she is in the reproductive age group. So the most probable cause is polyp, adenomyosis, or fibroid. If she has any high risk factors, like she's obese, she's hypertensive, she's perimenopausal age group, then the chances of it being malignancy are going to be more, right? So this is how you are going to be asked about your particular patient. Let's see another case of um, menorrhagia, right? So let's move to the next case. So the next case is a 22-year-old unmarried lady complaining of menorrhagia since last 1 year. The menstrual history is past 3 to 4 days. The past menstrual history is since last it is for 3 to 4 days duration, and it comes every 30 days, and there is no history of any dysmenorrhea. But presently, the duration has increased to 8 to 10 days, and it comes every 30 days, and there is history of dysmenorrhea. Right? Now look at the age of the patient. This patient is now 22-year-old and she is unmarried. Right? So per abdomen, the abdomen is soft. Right. Per speculum, the cervix is healthy, vagina is healthy, and per vaginum, the uterus is 8 weeks, anteverted, anteflexed, and fornices are free. Right. Now coming to the next case of menorrhagia. See another case in which there is a 40-year-old case who is para 3 living 3, comes with history of menorrhagia, dysmenorrhea, dyspareunia, irregular cycles with heavy bleeding. She also has tubal ligation done. Her past menstrual history was 3 to 4 days duration. Every 30 days there was no dysmenorrhea. Presently, this patient has the duration has increased to 8 to 10 days. It it comes every 30 days, and there is now dysmenorrhea, right? So on general examination, the findings are normal. On per abdomen examination, the abdomen is soft, and speculum examination reveals that the cervix is hypertrophied. See now the findings of the uterus. The uterus is enlarged. It is around 6 weeks size of gravid uterus. Always we compare a gynec uterus with that of the enlarged uterus during pregnancy to just imagine or to uh, imagine the size of how much increase it has undergone. So it is anteverted, anteflexed, regularly enlarged, mobile, and bilateral fornices are free. So this patient again fits into the palm category because her age is, look at the age is 40-year-old, right? Now the previous patient which we saw here, I'll just show you this patient, Menorrhagia. She also fits into the, look at the examination part. The uterus is bulky, right? So this patient also falls into the palm category. So always remember in exam, say palm if you find the uterus is enlarged, right? So this is another case of unmarried patient. Now this patient, though she is unmarried, they have done per speculum and per vaginum examination. So there should be a history of whether she is sexually active or not has to be asked before doing a clinical gynec examination, right? So this was another case which we just now saw, that is 40-year-old having menorrhagia, right? Now coming to the next case, that is, let me see. Yeah, now this is a case of 45-year-old lady who has menorrhagia since 6 months, and there is history of passage of clots and dysmenorrhea. No, the duration has increased to 8 to 10 days. On general examination, you will find that per abdomen mass is felt arising from uterus. It is around 16 week size now. That means it is abdominally palpable, right? It is firm, movable from margins, and the lower margin of the this thing is not reached. That means it is a mass arising from pelvis, right? Now coming to the per speculum examination, the cervix and vagina are healthy, and in POEV examination, the cervix is midpost, the uterus is enlarged, it is 14-week size, mobile, anteverted, anteflex. So looking at the size of the uterus and the age of the patient, that is she is 45-year-old and the uterus is 16-week size. So out of palm, right, polyp, adenomyosis, then malignancy and fibroid, the most common cause could be the fibroid because this patient is not perimenopausal. Perimenopausal is around 50 years or so, and at the same time, this patient is having a large uterus. So adenomyotic uteri are not more than 10, 12 weeks or so, at the most 10 to 12 weeks. Polyps are very small, they are intrauterine structures. The uterus could be even normal size for them. So for such a large uterus, it is most probably going to be fibroid, right? So such cases are going to come in exams. So now, how do you proceed? They will ask you now, they are going to ask you how are you going to manage this patient. So the answer is going to be, we would like to investigate her first, and we would like to treat according to the investigation reports once we reach to a definitive diagnosis. So looking at the history and clinical examination, you are supposed to give a clinical diagnosis. So clinical diagnosis will depend upon the age of the patient, the history, the clinical examination findings, right? So every patient in this three, four examples which we saw could have a similar differential diagnosis, but the first probable diagnosis is going to be different for different patients, right? So, say for that 22-year-old girl having menorrhagia and normal size uterus, if it is there, then most probably it could be a small polyp, or it could be that there is some hormonal change in her. There is because of stress also, there can be little bit of menorrhagia, but most probably there is some local cause which can lead to menorrhagia. In the reproductive age group, if patient has just one single episode of menorrhagia, then you must rule out pregnancy related cause, right? So first, by all the points or the template which you have got, you have to give the clinical diagnosis. for that particular patient. It cannot be a definitive diagnosis. You have to give two or three differential diagnoses clinically. So if it's a 14-week size uterus, your first clinical diagnosis is going to be fibroid uterus. Then it is going to be maybe malignancy. The chances of it being a polyp and adenomyosis are very less. It could be that a fibroid is associated with adenomyosis, right? So it will depend upon the clinical findings, and it will depend upon the age of the patient also. So, and the type of symptoms which the patient has. Now the next question which the examiner will ask you is, how are you going to investigate this patient? So as I always say in OBGY, at least say in specific diagnostic tests, ultrasonography. So ultrasonography pelvis is to be done for every patient to have the diagnosis for that particular case. Almost 90% of the cases will be diagnosed by a pelvic ultrasound. Other investigations which are hematological, like complete blood count, blood sugar, all those things will be done basically to see the general condition of patient. If she has, uh, if she is having lower hemoglobin, that shows that her health is really getting affected because of menorrhagia. Thyroid tests you are going to do, because most of the women around 40 may have thyroid disorder, and that itself could be a cause of menorrhagia if other local causes are not found, right? And if with all this you find there is a fibroid uterus, now the management of that patient will depend upon the age of the patient, the size of the fibroid, and the symptomatology which the patient has. Say any age of the patient. Say for that matter, she is 18-year-old and or she is 40-year-old. You have just she has mild menorrhagia and dysmenorrhea, and it's a just 2.2 centimeter fibroid, right? 2 by 2 centimeter fibroid. If she can be managed medically, by all means you would like to avoid surgery, right? If the patient has a 8 by 8 centimeter huge fibroid. So such fibroids increase in size because they are estrogen dependent. So even if she is not symptomatic, they are going to cause pressure symptoms. So in such patients, you will have to operate, and the route of surgery will depend upon the site of the fibroid and the size of the fibroid, right? So most of the time, the management of the patient will depend upon the age of the patient, the desire. There are three functions of genital tract. One is the menstrual function, second is the reproductive function, and third is the sexual function. So depending upon the age of the patient, you will decide which treatment is going to be best for a particular patient. So for a younger patient, all these three functions are needed. So you are going to be more and more conservative. For a perimenopausal age group, it is only the last function, the sexual function will be needed. So you may go ahead with hysterectomy if required. But for all given possible diagnosis, if at all possible, except for malignancy, if at all possible, it is always desirable to conserve the uterus and ovaries unless there is a high risk of developing malignancy because of family history or some other associated pathology. You should try to conserve the uterus, right? So, say patient is 22-year-old, uterus is normal size, maybe she's married and now she's desirous to conceive, and she has menorrhagia also. So, you have done sonography, you have done thyroid test, you have done everything, and you're not finding anything in the diagnosis. So, what are you going to do? You will have to look inside the uterus. Is there any local pathology which is very small and causing problem, and at the same time not visible? So, what are you going to do? You will do a hysteroscopy, right? So when nothing is visible, when all the investigations in the general examination in the of the general condition of the patient, endocrine function of the patient, and at the same time ultrasound are not showing anything, then the next step is going to be doing a hysteroscopy, right? But otherwise, if the patient is say 38-year-old, 35-year-old, there's a huge mass in the pelvis, and on ultrasound, if you find a fibroid, then it will depend upon what is she desirous of. At 38 years of age, if she is desirous of future fertility, then you may just go ahead with myomectomy. Then the route of myomectomy will depend upon the site and size of the tumor. If it's a submucous small fibroid which is jutting into the endometrial cavity, then you would like to go ahead with hysteroscopic removal. If it's a small fibroid which is subserous, and that means coming into the peritoneal cavity, then you would do that laparoscopically. And if it is an intramyometrial fibroid, neither inside the getting into the endometrial cavity nor into the getting into peritoneal cavity. You will have to do it laparoscopically, right? Now, if the patient says that, I'm not willing for any kind of surgery, can you manage me medically, right? Or if she wants to buy time for, she wants to travel abroad and maybe her relative is not with her and she says that, no, no, I don't want to get operated, what will you do? So there is something we have to do medically, we have to manage. So in such patients, you have two options. One is you are going to treat her menorrhagia, which is her basic symptom. So that can be done by hemostatic agents. And another thing is by hormones, right? So by giving hemostatic agents, NSAID group of drugs, you can use antifibrinolytic like ethamsulate. So all these drugs are used. Along with that, if she has dysmenorrhea, you will have to give anti-inflammatory drugs also, antispasmodic drugs like mefenamic acid along with hyoscine. All these drugs are given symptomatically to reduce her bleeding. Mefenamic acid reduces the bleeding also because it has effect on the endometrial vessels also. And so you're going to give her symptomatic relief for that. And to reduce the endometrial growth and the endometrial hyperplasia, you are going to give her something hormonal. Hormonally, you can treat her. So you can give her oral contraceptive pills, which can suppress her HPO axis and cause endometrial atrophy. You can give ulipristal to her if she has fibroid. So depending upon the condition, you are going to treat her medically. But polyps, adenomyosis, generally big fibroids cannot be treated medically. But yes, symptomatically to buy some time, you can treat them hormonally and medically. You can also use GnRH antagonists and analogs to reduce the size of fibroid if you are planning to operate or you want to buy time for the future surgery. So this is how a case of menorrhagia is going to be discussed with you. So you must first of all read the history properly. Any other elaborative findings, if they are going to ask you, you must tell that you are going to ask her how much is the amount of bleeding. They are going to ask you how are you going to quantify that bleeding. So clinically, by asking history of passage of clots is a very important history which is asked. The cause for that you must know that there is a role of fibrinolysin in it. Then the whole viva of any abnormal uterine bleeding is going to be on the etiology, that is palm and coin. Palm is local causes, coin is systemic causes. So all of you should know this mnemonic palm and coin. They have made it very clear. Palm is local causes of the uterus and coin is systemic causes of the menorrhagia. Then there are all these other symptomatologies like menorrhagia, polymenorrhea, metrorrhagia, post-coital bleeding. All these things can be added to the patient's history to know if she has any local pathology, right? So on general examination, the positive findings which you are going to look for any menstrual abnormality are pallor, then um, any thyroid swelling, is she having any acne, hirsutism, and hyperandrogenism, and these are most common things which you have to see. Is she hypertensive, is she having any diabetic history in the history, and then in examination you are going to see for any lump in abdomen, right, and which is seen or palpable. And in TV examination, if they have given you findings like enlarged uterus, the enlarged uterus up to 10 to 12 week size could be any cause of palm, right? But if it exceeds beyond 12 weeks, if when it is palpable per abdomen, 16 weeks, 18 weeks, 20 weeks size mass, then most probably, whenever it is associated with menorrhagia, most probably it is fibroid uterus. It could be a hormone secreting ovarian tumor also, but that's very rare. So palm may you have must remember polyp, adenomyosis, malignancy, and leiomyoma. Right? Now, in Gynec, in investigations, always rule out anemia, diabetes, hypertension, thyroid. Four things you have to investigate in the patient. If she has any history of systemic disorder, or if you want to plan surgery, you are going to go ahead with HIV, HbSAg, LFT, KFT, liver function test, kidney function test if you are planning for a surgery, right? And then otherwise the specific one investigation which you would like to locate or to diagnose your pathology is going to be non-invasive, is going to be ultrasound pelvis and abdomen, mostly the pelvis. Once you have diagnosed it, the management will depend upon the age of the patient, whether she is desirous of menstrual function, whether she is desirous of reproductive function, and whether she is desirous of sexual function. Now, these three functions of genital tract are always kept in mind whenever you are managing any gynecologic case, whether it is prolapse, whether it is fibroid, whether it is infertility, whatever. So all these three functions have to be kept in mind before you go ahead with treatment of the patient. And the treatment will be depending upon the cause of the particular condition, right? So I think we have discussed uh, everything about menorrhagia or any case of abnormal uterine bleeding, and any questions you can have, uh, you can always share with me in your WhatsApp group. Thank you so much.